everyone, and welcome to this webinar called PFO Closure with the Amplatzer Talisman PFO Occluder in patients older than 60 years. So during this webinar, we're going to discuss new real-world data, which is providing additional information on how to use PFO closure to prevent recurrent ischemic stroke. My name is Lars Sondergaard. I used to be an intervention cardiologist, but is now the Chief Medical Officer for Abbott Structural Heart. And it was a big pleasure to be joined by two experts in this field, Dr. Ruby Satpathy, who is an intervention cardiologist in Jacksonville in Florida. Ruby has been heavily involved in both guidelines and consensus in intervention cardiology. And also Jeff Saver, a stroke neurologist in LA in California. And also Jeff has been very much involved in the PFO field for more than a decade. What we're going to do today is that we're starting off to have an overview of the current guidelines and literature on PFO closure in patients older than 60 years. It's going to be Dr. Ruby Satpathy who's going to give us that. Afterwards, we're going to move to Jeff Saver, who's going to present these new real-world outcome of Amplatzer Talisman PFO Occluder in US Medicare beneficiaries who's older than 60 years of age with presumed PFO-associated stroke. And then afterwards, we're going to discuss among the group of us on how these new data is impacting our clinical practice. A few housekeeping. First of all, this webinar will be recorded, so there will be possibility to see it on demand afterwards. We also want this webinar to be as interactive as possible. So I'm going to encourage you to, during the webinar, to send your questions or comments in the Q&A feature on your screen, and we'll try to address it during the webinar, or there will also be allocated time at the end of the webinar to have these discussions. And finally, we want to have some feedback on the webinar. So after the webinar, there will be a survey. Please provide your input so we can use that as we move forward. We'll start with one poll here, a question about your practice today. So the question is, do you currently refer or close PFO in selected patients older than 60 years of age? So there's three options here. Yes, no, or this doesn't really apply to my current practice. So please provide your answers here. And while give it a few seconds, I mean, we have also, and be coming back to this, we have, of course, all the guidelines which strongly recommend to close PFO in patients up to 60 years of age. And again, as this discussion today is what evidence do we have for patients older than 60 years of age to also offer this treatment? We will give it a few more seconds for everyone to have a chance to provide the answers. So let's move on here to the answers. So again, the question was, do you currently refer close PFO in selected patients older than 60 years of age? We can see that around 50% of you, 51% to be accurate, is doing this. About 1/4, 22.4%, are not offering this treatment currently, and the remaining quarter is not relevant for them right now. So I think we should start now here with about what is the current evidence for this. So Ruby, can you please take us through this?
Thank you, Lars. Hello, everyone from Jacksonville, Florida. So over next about 8 to 10 minutes, I'm going to walk you through what we know in terms of guideline and literature on patients who are above 60 years old. Now, we can't do that without a little background on what the PFO is. And it is, we all know this, but just as a refresher, so 25% of people have PFO, and everybody does not have stroke or migraine. So, but when the patients have PFO, some of this blood, if you would say the neurochemicals or tiny clots, are going through this PFO to the left atrium without going through the normal circulation or pulmonary circulation. And just to refresh our memory again, and we'll talk about this in this next few slides because it's very important in both patients less than 60 and above 60-year age, is the size of the shunt, how big the PFO is, 2 millimeter, 5 millimeter, how much blood is shunting, and that we know that by bubbles crossing. We can do that by echocardiogram, either regular 2D echo or a transesophageal echocardiogram or TCD. And they're grading up the shunt 1, 2, and 3. Everybody should do that because it's important, again, to decide what work we should do on these people, both less than 60 and above 60. And then the other high-risk features are aneurysmal septum and association of the eustachian valve, because they both increase the amount of shunting, at least in half of the 50% of respiratory cycle, because they're directing more blood to the left side directly. So with that in the background, let's talk about the stroke etiologies, right? The ASCOT. So as you can see, a lot of times the stroke has a cause, and it could be atherosclerosis, it could be small vessel disease, it could be a cardioembolic stroke from AFib or endocarditis, or it could be dissection or other pathology. Now, when we don't have any of those causes, this term was coined called the cryptogenic stroke, when we don't know what the cause is. There was a point about 5 to 7 years ago, we coined a term called PFO stroke, because we said, well, when we have a PFO, we know there is a mechanism for stroke, and this should not be any more a cryptogenic, this should be called a PFO stroke. And that debate still is ongoing. We know now that PFO is one of the known causes of stroke. We have lots and lots of studies that has looked at PFO mechanism and stroke, the association, and what we should do. PFO closure versus medical management. Is it double antiplatelet? Is it anticoagulation? We won't have time to go over all the studies, but we're all happy to take any question answer at the end. Moving forward, what do we know? We cannot go to above 60 without understanding what we have evidence for people less than 60. And we have, again, a lot of evidence now for people what we should do for patients who are 18 to 60 years of age. Just to refresh our memory, Association of Neurology recommends for patients who are younger than 60 with a PFO, with the embolic appearing infarct and no other mechanism of stroke identified, we recommend closure following discussion of risk and benefit with the patient. 2021, American Heart Association and Stroke Association recommends, again, if you have a non-lacunar ischemic stroke, so embolic infarct, undetermined cause despite a thorough evaluation, and PFO has high-risk anatomical feature, which I touched upon on the first slide, we should choose closure and long-term antiplatelet over medical management alone. 2022 SCI, which is Society of Interventional Cardiology, recommends PFO closure rather than antiplatelet therapy alone, independent of patient anatomy. So what do we do with patients who are above 60? Now, as you all know, and I'm sure you all agree, in our practice, we see above 60-year, very, very common incidents now. And I think two things are happening. People are living longer. It's a good thing. We have lots of people are living healthy life, and we're seeing a lot of young 65, 70, 75-year-old with not much comorbidities. And so the platform is changing as we're talking, and we're seeing a lot more people living longer and living healthier without much comorbidities. So that brings us to what we do in these people. So let's understand what we know about in the literature so far. Only one study, the number 3, is actually a randomized trial. Everything else are small observational studies on patients who are above 60. The Defense PFO had a sub-study in the number 3 randomized trial. Number is very low, but it basically showed PFO occluder is effective in preventing recurrent stroke. The others are observational studies. They are small sample sizes, as you can see, unmatched cohorts because it's a retrospective analysis, but all of them basically are showing PFO occluder 2 things. One, it is safe. It's a very low-risk procedure. People do well, and it is associated with a lower rate of ischemic events. So what do we know at this time in terms of consensus statement or guideline for patients who are above 60? Let's go back to, again, 2020, Association of Neurology. PFO occluder may be offered in other populations, such as patient who is 60 to 65-year-old with a very limited degree of traditional vascular risk factor, which are obviously hypertension, diabetes, hyperlipidemia, or smoking, and no other mechanism of stroke detected following a thorough evaluation. And when we say thorough evaluation, make sure we do a few things. One is the carotid ultrasound and a longer monitoring for atrial fibrillation. This is where the link type of stuff comes in, and a lot of studies show, and we'll talk a little bit later how we practice in our institutions. 90-day data is good, but you need to wait a little bit longer than 2 weeks, 4 weeks, to be 3 months. 2021 AHA/ASA recommendation: PFO occluder should rarely be performed in older people and only in very unusual circumstances because we don't have a lot of evidence at this time. 2022 SKY panel recommends 60 or older with a prior PFO-associated stroke. SKY guideline panel suggests PFO occluder rather than long-term antiplatelet therapy alone. Going to European societies, European Society of Cardiology. So there are 2 types of scores out there. One is ROPE, which is the risk of paradoxical embolism. And we know that the ROPE score was usually going to be lower when you are looking at patients above 60, just because of that age factor to begin with. And then the other score that's out there that I think we all should be looking is called the Pascal. Pascal is basically possibility of causal association of PFO for stroke, which basically looks at the high-risk anatomical features of the PFO that we talked about. So what does the European Society of Cardiology recommends? Assessing overall thromboembolic risk for patients above 60. Patients are at moderately increased risk if they have recent DVT and PE and a high-risk PFO, because that is basically suggesting it is a paradoxical embolism, regardless of the ROPE score. Slightly increased risk when we call the Pascal, as I was talking, possible. Pascal says possible, probable, or unlikely. Pascal possible with most likely was a possible cause. These are the high-risk PFO features, which are basically is a large shunt, atrial septal aneurysm, and a bigger, the tunnel is bigger, more than 2 millimeters. And the ROPE score above 7. The second is recent DVT-PE with low-risk PFO, again, because that is suggesting paradoxical embolism, and then regardless of the ROPE score. 2024 European Stroke Guideline says patients older than 60, we have very low evidence. It encourages doing randomized trial, including patients above 60 years old, and suggests using Pascal and other clinical judgment and having the risk-benefit share decision-making to guide therapy. So at the end of the day, what we know so far, as I suggested and went over, is we have limited evidence, mostly observational studies and small sample size and unmatched cohort. And at this time, above 60-year-old patients, it's important we have a risk-benefit discussion, but we're seeing a lot of them, and people are living longer and they're living healthier. And so I think it's very important that we discuss how we handle this large size, complex patient population that might benefit from this therapy. So at this time, I'm going to hand over to Dr. Sever, and Jeff is going to go over the real-world outcomes of Amplatzer Talisman PFO Occluder that we looked at in U.S. Medicare beneficiary who are above 60 years old with a presumed PFO-associated stroke. Jeff?
So Ruby, that was a great, and just before you start, Jeff, maybe I can just ask you a few questions, Ruby.
Sure.
It's all about selecting the right patients. And you talked about two scores, the ROPE score and the Pascal score. Can you explain what is the ROPE score for people who have not been using that, and how can that be used to guide you in selecting the right patient, just with the ROPE score?
Perfect. So now, to make it easy, everybody, it's a very easy score. And in fact, there is a nice little app and that you can also save on your phone. I always tell in our hospital, all our APPs and hospitalists and neurologists and cardiologists, it's just like a little, CHAD score that we do for AFib. So it takes into account multiple things. Age is a big one. So patients, when they're younger, they're getting a higher score or higher number, if you'd say. And then the type of stroke. Is it a lacunar infarct, a cortical infarct? What is the MRI showing, which suggests is it embolic or it's a small vessel disease type of stroke? It takes into account the risk factors like hypertension, diabetes, carotid disease, smoking. And so it's a little algorithm, and the idea is the higher the score is, which will be usually if they're young, but also if they're healthy and no other comorbidities, the higher the ROPE score, most likely the PFO is associated with stroke and they benefit from that PFO closure. But here is where I think we have to develop something as we go forward, something like ROPE above 60. Because yes, the ROPE score will be a little bit lower on patients who are above 60 just because of the age criteria. But when we have patients who do not have another mechanism of stroke by a thorough evaluation, even if their ROPE score by itself might be a little bit lower, this is where it's important that we develop, and that's why I brought up the Pascal. It's important to look at the anatomical features of the PFO. How wide is the shunt or the tunnel? Is it 1 millimeter? Is it 5 millimeter? How much bubbles are crossing? Is it 0 to 10, 10 to 20, and or more than 20, which is again an important thing for everybody in clinical practice when they're doing a TCD or echo, either 2D echo or T. Remember to do a cough, Valsalva. I see a lot of times one echo report comes back negative, and the other echo or TCD is positive. So if you have a high suspicion that patient does not have another reason for stroke, it's okay to repeat with a good Valsalva. I see it more on TEE because patients are sleeping and they can't cough. So just keep that in mind. And then again, the other is that atrial septal aneurysm, which is associated with 10 times increased risk for stroke and paradoxical embolism. And at the end of the day, if you have a DVT and PE and stroke at the same times, in my mind as a clinician, it's usually associated unless proven otherwise.
Yeah, so that's great. I mean, as you said, the ROPE score take this baseline demographics into the consideration. So you score between 0 and 10. The higher score, the more likely is the stroke is PFO associated. And the Pascal is looking at the PFO, big shunt, and aneurysmal septum, which is going to add on to it. So I think this is a very clinical, useful tools using the ROPE score and the Pascal, at least in younger patients. And as you rightly said, we need to take into consideration these patients will score low because they're over 60 years of age. So we need new tools if we want to select these patients as we move forward. Thanks a lot, Ruby. So Jeff, let's move to you and tell us what new insight do we have from real world data in this patient population more than 60 years of age.
Thank you, Lars and Ruby, and hello from the other coast, from Los Angeles to everyone. And I'm going to be presenting some new data on much larger than the existing data sets that Dr. Satpathy has reviewed on actual real-world outcomes with PFO closure in patients over than age 60 in the US. And this is data that was presented at the European Stroke Organization conference meeting this year. And the full-length paper for this study is currently nearly finalized and soon to be submitted to a journal. So this has not yet appeared in the full-length literature. The abstract has been published, but I think it's very interesting new data. Here, I'm now going to take you through the slides that were shown at the meeting, and here you can see the co-authors of cardiologists, neurologists, and other experts who worked on this study. We announced our disclosures and indicated the background for undertaking this study is, as we've just seen, we know from RCTs that many patients, most patients with cryptogenic stroke, otherwise cryptogenic stroke, and a PFO will benefit from closure if they're age 18 to 60, but data in patients over 60 is currently very limited. And so this study was undertaken to assess the outcomes of US patients in Medicare older than age 60 who received an Amplatzer PFO Occluder, either the Abbott Amplatzer or the Talisman. And we compared those to patients with an ischemic stroke likely related to the PFO who were treated medically. To do this, we used two different national data sources, the Medicare claims database and Abbott's patient device tracking database. And that allowed us to determine which patients had had an ischemic stroke in claims data, and then subsequently, within the next 6 months, had an implant of a PFO occluder. And it also allowed us to identify medically treated control patients who were patients who had an ischemic stroke and also had a diagnosis in claims data of a PFO or ASD, predominantly PFO, and who did not undergo a closure procedure. And then we use propensity scoring to match these individuals based on the variables of age, sex, race, and clinical characteristics. We then looked at the Medicare data to see outcome strokes over the next 3 years, as well as safety endpoints of all-cause mortality, atrial fibrillation, venous thromboembolism, bleeding events, and vascular access complications. So here is a schematic. The key inclusion criteria were to have had a ischemic stroke within 6 months prior to the start of the period that we followed that individual patient for, start of their 3-year analytic period. And they could not have had, they needed to have the PFO, and if they received the Abbott device as well, they were in the active group, no device in the control group. They could not have a history of atrial fibrillation. So here is the data. We identified over 5,500 patients over age 60 with ischemic stroke who had received an Amplatzer occluder. Of those, we were able to link to the same patients in the Medicare fee-for-service claims data, over 2,000 patients. And then after applying the study criteria, we had 1,132 patients in the device arm. And then in the medical arm, there were nearly 50,000 patients with an ischemic stroke, PFO, and no AFib. And after applying the study criteria, we had 20,000 patients eligible for the study. And then when we matched these patients 4-to-1 to patients in the who were eligible, we had a matched control arm of 4,300 plus patients. So here are the demographics of the groups. And you can see that before matching, the much larger control group and the device group do have some important differences. The control group was older. They were more less often white race, and they, in terms of frailty, they were less often low-risk frailty and more often frail patients who went into the control group. However, after matching, you can see we succeeded in identifying a control population that looked just like the device group population, well matched for age and for every one of the other clinical and demographic factors. So here are the outcome results for the effectiveness endpoint of recurrent ischemic stroke over 3 years. And you can see a substantially lower rate of events in the in green in the device group than in purple in the control group. The event rate per year in 100 patients was 1.65% in the device group versus 2.66% in the control group. So this is a absolute reduction of about 1% per year and a relative reduction of 0.62, 38% relative risk reduction. And this was highly statistically significant. Here's the outcomes for the safety endpoints. No difference in mortality. There was an increase in atrial fibrillation. We don't have data on the duration of the AFib, but likely many of these were transient events soon after the devices were placed, although some undoubtedly are also longer lasting events. Higher occurrence of venous thromboembolism in device patients who were not receiving anticoagulation, and very undetectably low rates of major bleeding requiring transfusion and also of vascular access complications. When you do this type of propensity matching, it's good to choose some falsification endpoints, other disease states that you follow these same patients for over the 3 years to see if they differ in these other diseases. If your matching was not good and you still have patients who are sicker in one group than in the other group, then these other diseases will occur more often in a particular group. But if the other diseases are occurring equally frequently in the two groups, but your targeted disease is different, then that suggests a true causal relation. And you can see for the 13 falsification endpoints, we found a very good balance. 11 of the 13 showed no difference whatsoever, including cardiovascular outcome of myocardial infarction. And 2 endpoints differed, but 1 favored device, 1 favored control, so no directionality. On the other hand, there was a difference in 3-year mortality with a increased mortality rate in the control group, and that suggests that there may have been some residual confounding, and we therefore did an additional analysis, propensity matching for the occurrence of mortality. And when we took patients when we removed patients who would be having early deaths from the group and looked at the rate of recurrent ischemic stroke, we still saw a treatment effect that was in the same direction and approximately the same magnitude, a 28% reduction over 3 years for the point estimate. In this smaller sample, after taking the patients out, the p-value was 0.16, but the indications suggested that even after accounting for mortality, there's evidence of a treatment effect from the closure. When we looked at different patient subgroups, there was one subgroup that, first I'll say, across many subgroups, there was no difference across different ages, different sexes, races, no difference. The frailty scores, a hint that if you had high frailty, then there was not as much of a treatment effect than in patients with low and intermediate frailty. Also, interestingly, directionality suggesting a stronger effect in patients with a history of migraine. This real-world study is, of course, subject to the limitations of any real-world study. Patients were not randomized, and residual selection bias or confounding may exist. Also, the study was limited to the Medicare fee-for-service population. Its generalizability to the Medicare Advantage HMO-like population and non-Medicare populations is warranted. We also had limited information from the claims data, making us unable to distinguish between PFO and ASD in medical codes, but overwhelmingly these cases would have been PFO. We were not able to obtain information on PFO size in the presence of atrial septal aneurysm, so could not use Pascal scoring, and the severity of the strokes is only incompletely captured in with a lot of missingness in the data, and the antithrombotic regimens that patients in both groups were treated with, we assumed that we started our observation period for the control group 6 months after the ischemic stroke, similar to that for the closure group, but the index date may have differed. So we concluded that this data represents the largest study in real-world data in patients receiving devices over age 60, and also the largest comparative study to patients treated with medical therapy. The recurrent ischemic stroke rate after PFO implant in these older patients is comparable to that reported in the literature post-closure for older patients. The effect size in reducing recurrent stroke was mildly lower in these older patients, 38% relative risk reduction compared to the 59% seen in under 60-year-old patients in the randomized trials, as we might expect for patients with a wider range of other causes of stroke. But you can see that the current study is 3 times as large as the largest prior study with real-world evidence, and the only study with real-world evidence able to compare with medical therapy, and approaches the size and has similar findings to that of the pooled meta-analysis of the completed under 60-year-old randomized trials. The rates of safety endpoints were relatively low in this study, and so we concluded that in properly selected patients over the age of 60, PFO closure may be beneficial in reducing recurrent ischemic stroke with a low incidence of adverse events.
So Jeff, that was a great, I mean, I think this is super impressive data here in a real large scale and real world setting here. So there, I will remind everyone, please use the Q&A function, post your questions. We'll try to address them at the end of the session. There's already a few questions, Jeff. One is, patient who had a PFO closure in the past. I assume those patients were excluded from the study.
Yes, if you had a prior PFO closure, you could not get into the study in either group, the medical arm or the device arm.
Yeah, and also as you mentioned here at your last slide, the relative risk reduction was not as large as it was in the randomized trial, pooling the randomized trials. But again, the risk that the patient will actually have a stroke is much higher here. So I think the patient who potentially would benefit will, at the end of the day, be higher. More patient will, due to the high risk of recurrent stroke in this elderly population.
Yeah, you know, if you take the 1% per year absolute risk reduction, then at 5 years, a 5% absolute reduction gives you a number needed to treat of 20. If you go out to 10 years, which one has to be very cautious with, since we only have an observation period of 3 years, then you have a 10% absolute reduction, a number needed to treat of 1 in 10. So it is this treatment effect magnitude is clinically impactful.
So Jeff, before you start telling us how this have impacted your clinical practice, you are a stroke neurologist. It's you and your colleagues who's often the gatekeeper for sending patients for PFO closure. How have these data been received in the stroke neurologist community?
Well, I can say that at the meeting at which this was presented, there was exciting excitement in the room. The abstract that was supposed to be presented after this one had been withdrawn, so there was a longer question period than usual, which was good because people had a lot of interest. I think people felt that this was providing very useful first data of large size to help inform treatment of these patients. You know, neurologists tend to be somewhat evidence driven and strongly evidence driven. So there was still a desire to see randomized control data to have definitive guidance, but this was seen as very useful initial information.
Yeah, and I know that you know, in 2017 we saw those 3 simultaneous publications in New England Journal of Medicine, 3 studies showing a positive effect of PFO closure in patients less than 60 years of age. One of them was called CLOSE, the study. There's actually CLOSE 2 is running now. It's actually randomizing exactly this patient cohort. So we will get harder evidence as we move forward in this field. Jeff, so please tell us how these data impacted your own clinical practice.
Okay. So now Dr. Satpathy and I are going to tell you how we incorporate this data into our practice. And here is my one slide snapshot. First, in thinking about patient age, to make the distinction between chronologic age and physiologic age, we all know that there are 65-year-olds who look 50 years old, and there are 50-year-olds who look 65 years old and act and have the biology to go with it. So think about the actual biologic age of the patient, and then the age 60 was a somewhat arbitrary cutoff to entry criteria for these trials. Patients don't go from being carriages to pumpkins at the strike of midnight on their 61st birthday. So I think that the closer patients are to the patients in the trials, the more we can expect the data from the trials already provides us with evidence that in select patients there'll be benefit. So in patients in the 61 to 65 range, I think of them as often like under 60 and often take the same approach. I am more patient individualized in 66 to 70-year-olds, and over 71, I tend to do medical therapy except in unusual circumstances. And in those over 60 patients who I am going to proceed to closure, they have to have first an otherwise cryptogenic stroke. They have to have either or both of a large shunt or an atrial septal aneurysm as a PFO risk factor. They have to have a paucity of other vascular risk factors. They need a embolic pattern to their stroke, and I will do longer cardiac monitoring, 1 to 3 months, looking for subclinical covert atrial fibrillation, which is age-related and is going to be a more common occurrence in this population. And then, in addition to this general framework, additional features that in individual cases push me up or down are whether there was a Valsalva at onset at the time of the stroke, coexisting DVT, the patient has a hypercoagulable state, if there's a bleeding risk that would make me want to avoid anticoagulation, and other patient individual risk factors. So that's my approach, and now I'll turn it over to Ruby.
Before Ruby start, there's a question here in the chat about what is, when is a PFO clinical significant? I mean, we're talking about high risk PFO, and you have it here on your list. So maybe you can just explain what is high risk? What is the number of bubbles going across? How do you measure how much atrial septal aneurysm you have? Just very practical.
Sure. Well, the standard definition of an atrial septal aneurysm is 10 millimeter or more excursion. And for shunt size, the approach that was used in the clinical trials was on transesophageal echocardiography, a bubble count of 21 or more bubbles. So that's the only clinical trial validated approach to physiologic shunt size. And like Ruby, I dearly wish that cardiologists performing TEs increase the rate of their reporting of actual counted numbers so that we can apply the clinical trial evidence. On transcranial Doppler, the Spencer grades from 1 to 5 tell you the size of the shunt. 4 or 5 are very large shunts. 1 or 2 are small shunts. 3 is kind of intermediate. So if there's a 4 or 5, I think that would be a green to go in terms of having a risk factor. And then in addition, there's the direct measurement of the size of the tunnel, which was not used in the trials, but of course is another route to get reliable information on shunt size.
So there's one more question. Maybe you can address that, Jeff. You said you did 3 months monitoring for AFib. What kind of device did you use for these patients? Did you all have a loop recorder or what?
Well, if I'm I do 1 to 3 months. In a 61-year-old, a 62-year-old, I might do just 1 month and there do patch monitoring. If I'm going for 3 months, I will lean to using a loop recorder. Using a loop recorder is going to have a potential double payoff in these patients, that it will let you monitor for those first few months to see if there's a competing atrial fibrillation risk. But then also, if you do proceed with closure, it will let you monitor for the occurrence of atrial fibrillation post-procedure, which of course is a known risk of the procedure. So it's something I have a relatively low threshold for using in these older patients.
Yeah, that's great. Ruby, so let's hear how this has changed your practice.
Sure. So great presentation, Jeff, and thanks, Lars. Let's move on to see what we do. So couple things. One, before we go into the real PFO, we all know between cardiology and neurology, there is true stroke and there is the stroke mimics. So I think it's important that we, again, it's a teamwork, a lot of times cardiology and neurology together, that we differentiate what is a true stroke versus to what the patient thought they had a stroke. And it could be a complex migraine, it could be a lot of different things. So I think it's very important as clinician, the responsibility lies on our shoulder that we actually are having this discussion when we truly think it's a PFO stroke or it's a stroke. There is a question in the chat, and maybe I'll just answer that now, I think somebody asked, what do you do when you have TIAs, but they're imaging negative events? And we all know that patient could have, if they present early, we have seen a lot of times in our stroke center, patient come with classic symptoms of stroke-like features, and they get TPA, MRI later is negative, but they had classic signs. And so you could consider those patients as a true stroke. Again, it's a clinical decision, and proceed with the PFO closure if they truly have a PFO and there's no other reasons for stroke. I think it's important. About 8 years ago at Baptist, we decided to do a PFO team approach, and we kind of got this concept from the heart valve team that we have been doing for about 15 years, and instead of the cardiology and CT surgery, how we address our valves, aortic TAVR or MitraClip, I switched the CT surgery to neurologist. And then we include a hematologist if we have to, if there is a question about if they have hypercoagulable, one of those heterozygous factor positive, do they need long-term blood thinner, what's their risk? And that's, again, a case by case, and the imaging specialists, and a lot of times it could be a radiologist or a cardiologist or a neuroimager. But it's important that in these cases, especially all strokes, but if we're getting to the more than 60, that we have a multidisciplinary team approach. So I thought I'll share this. Can we put the, thank you. So this is a 66-year-old female who is a retired nurse. I chose this case to kind of show that how a 65 could be like a 50, and then the 65 could look like a 90. And this retired nurse comes to the ER with a left-sided weakness and tingling, and improves after TPA, no residual deficit. And you can see the color on both the short axis and long axis. The PFO did not have any comorbidities. Patient was discharged on aspirin Plavix. One caveat here is when you have somebody who has, we talked about, I think some questions are there in the chat box here, is what's the degree of shunt? I have mandated as the head of the program, going back to Jeff's point, that all cardiologists should report when they're doing the echo, transthoracic or TE, starts at the echo tech level, that we comment on the degree of shunt, because it's very important clinical when somebody is looking, is it, how many bubbles? So grade 1 is 0 to 10, grade 2 is 10 to 20, grade 3 is more than 20, which is same as the Spencer grade 4 and 5 on TCD. It's a large shunt, and the timing is also important. Is it something that comes after 10 cycles? That's probably more suggestive of a pulmonary circulation shunting, versus if it comes in the first 2 beats, then it's likely the PFO, intracardiac shunting. So and if there is a large shunt, grade 3 shunt, a lot of times in a young patient and had a large stroke and recovered, we will choose sometimes a low dose Eliquis instead of DAPT. And again, that's another topic by itself, but it's surely worth, if we think the recurrent stroke risk is high, we would elect sometimes, looking at the risk and benefit about NOAC versus, or anticoagulation versus just double antiplatelet. So we elected to do a link monitor on this. And again, the long-term monitoring in our practice, if they are 61 to 65 healthy people, I think a 30-day monitor is okay. If they're above 65, and if they have some risk factors like hypertension or smoking, especially if they have diabetes, I think link is a good idea, because there are at least a couple studies out there shows that 30-day you may not see it, but by 90 days you get the occult AFib, it shows up. So I think it's important, and you can stay up to 3 years, so you certainly can watch their rhythm for up to a year after the PFO closure. So in this retired nurse, we did implant the link, in 3 months, patient did not have an AFib, and we did a 30-millimeter cribiform device, and patient came off Plavix at 6 months. So not only patient got the device, so they're not worried about the stroke, and there is no bubble crossing, but also patient got off the blood thinner, which, as we know, Plavix has its own risk for bleeding events. The procedure itself is a very, as we saw in the studies, and it takes less than 30 minutes, and people are usually going home same day. They're walking in 3 hours, and it is a low risk procedure, as Jeff shared with the studies, and we talked about in my part of the talk with the observational studies that have shown that. So important 3 things. One, again, and very similar to what Jeff shared, what he does at UCLA. I think one important thing is a large PFO, which is, again, very important that we not just say PFO is present, but we say what is the grade of the shunt. And as I said in my first part, it's important that somebody did a Valsalva study, and it was a true Valsalva study. It wasn't a TE when they were completely out and somebody, thought they did a Valsalva, but patient could barely cough. So I think in that situation, if you have a high-risk suspicion, they're a healthy 65-year-old, they had a stroke, it's okay to repeat a TCD or a transthoracic echo when they're awake, and they can do a good Valsalva. Again, the true stroke, which is embolic pattern, not a small vessel disease stroke. And again, we talked about the longer monitoring, but important is if they're above 65 and they have some risk factors, I would usually do a 90-day monitor and link. Happy to take them.
Thank you, Ruby. So I mean, I think you both stressed that for these elderly patients, it's even more important to identify patients with high-risk stroke, big shunt, and arrhythmial septum than it is for younger patients. I mean, younger patients will have a lower threshold for closing it than these elderly patients here. So make sure you do that when you do your workup to have a good quantification of the shunts. Ruby, there's a question here about post-procedural antiplatelet therapy. So what are you doing in your practice? And is it different from what you're doing in patient older than 60 years of age than patient at a younger age?
Yeah, great question. Before I go to that question, before I forget, I do want to comment on something. I think it's important in this particular patient population that we're talking, more than 60. As we talk, they're living longer. We all are living longer, living healthier, less comorbidities. But also, people ask me why I have had this PFO for my entire life. Why do you think it caused a stroke when I'm 68, right? I think it's important that we all understand that as we get older, I think we are at increased risk for forming a little tiny clot, venous thromboembolism when we're sitting in the plane coming from California to Florida, even a 5-hour flight. I think we know the pathophysiology and the mechanism, and we are at increased risk when we get older for increased venous thromboembolism and increased stroke in general. So as this population is getting older, I think that's where it's very important, if they are healthy and if we think there was a paradoxical embolism and PFO is a cause, that they will benefit, even though the relative risk reduction may not be as high as less than 60, but they will benefit. Going back to the question, so 2 things. One, they could have been discharged after the stroke either on DAPT, aspirin Plavix, or sometimes on oral anticoagulation if it was a grade 3 shunt and we're very worried about a recurrent event. After the procedure, they don't need to be on blood thinner. If they were on Eliquis or Xarelto, that can be stopped, unless they have another reason to be on it. If they have a DVT, that's a different conversation. From day 1, they can go aspirin Plavix. We don't have to load like we do with stents, because this is a bigger device, but they have aspirin 81 and Plavix 75. 6 months is okay. It does take, the studies show that it can, and that the reason why we're doing this at this time is to help endothelialization of this disc, so it's completely healed. Most often, I would say 60% of cases, the pre-discharge echo or a week later, it's completely healed, no bubbles are crossing. But there is 40% of time we see a little bit of bubble crossing. Idea is when it's completely endothelialized, it'll be completely sealed. And that's where this aspirin Plavix comes. And usually I do 6 months. You can make a case for up to 12 months, but if they have to stop for a procedure, it's okay to stop Plavix sooner, 3 months.
So after those 6 to 12 months on dual antiplatelet therapy, will you stop the treatment completely, or will patient continue on aspirin if there's no bleeding issue?
I recommend aspirin 81 for the rest of their life. I think it's ideal. I do see in clinical real world practice, patients, younger patients especially, have a little bit resistance to going on aspirin. I think when we're dealing with more than 60-year-old, I think they should be on aspirin because of the increased risk in general for everything. If they are 20, I recommend, but I'm okay if they say I don't want to be on aspirin for next, 40 years of my life. So I think I would strongly recommend maybe aspirin for the rest of their life, and I would be more aggressive when they're above 60.
Jeff, there's a question also about the impact of age on these results. I mean, maybe you showed some subgroup analysis, but can you just repeat, does these findings in patients older than 60 years of age apply the same to patients between 61 and 70 or more than 70 years of age and so on?
So I think that's a great question. And again, I think it's a little early. We all are going to learn together. There is, and I think Jeff shared this, we saw that when we analyzed this study, there's a little difference. Now remember, our study is a US Medicare group, so it's just mostly above 65. So 61 to 65, the benefit, again, more to, in my mind, I think the same way that Jeff said, that it's just, whole body doesn't just switch at midnight when you turn 60. So I think 60 was randomly chosen, that age. And again, people at 61 to 65 are usually healthy and young. When you go to more than 60, then we divided, as it's shown right here, 65 to 70, 70 to 80, and age more than 80. And we're seeing the difference is more when they're 65 to 70. And again, I think that is because we have, these are usually younger and healthier population, versus when they're above 80, they might have developed some more risk factors. I can show
you, here's, I put on the screen the data from the real world study, and you can see that there's very comparable effects in the subgroup analysis in ages 65 to 70, 70 to 80, and over 80. Interestingly, there was less of an effect in patients 60 to 64, but that's likely because you don't really get into Medicare until you're age 65 or over. They are very unusual condition patients, 60 to 64, so that's not a very reliable group. But as you can see here, at least in this study, the effect was comparable across all the age groups.
Okay, that's great. I think we are almost at the end of the session. Before we stop, conclude, we just want to go back to, we have a last survey here. Let me see if we can find it. The last poll question here. It's coming here. So now where you have seen this evidence from real world data, have you changed your mind? So please answer here. A, I currently refer close PFO in selected patient older than 6 years of age, and these data further validate my approach. That's the first answer. Second one, B, I don't currently refer or close PFOs in patients older than 6 years of age, but I plan to reconsider this patient population after seeing these data. And finally, I believe more evidence is needed before I change how I treat patients older than 6 years of age. That's number C. So please answer the question, and we'll see whether these new data have changed your view on how to treat these patients. So while you are voting here, I would just say once again, remember, this webinar has been recorded. There will be an option to see it on demand afterwards. And also, there will be a survey sent to you. Please respond to the survey to give feedback on the webinar in order to improve these sessions as we move forward. Can give it a few more seconds for everyone to have a chance to respond to the questions. So Jeff, anything you want to say here before we conclude?
I would echo what Ruby said, that with regard to antiplatelet therapy, one aspect that neurologists and cardiologists sometimes differ on is whether to continue aspirin beyond 6 months. And I, like Ruby, do think that it's best to continue aspirin indefinitely, lifelong. The diagnosis of mechanism of stroke is always a probabilistic diagnosis. If you see a PFO straddling, a thrombus straddling the PFO, then we know, but in any other setting, it's probabilistic, and there could always be some other mechanism aboard, and aspirin is good for almost all other mechanisms of stroke. So I do think it's good to have people on a safe low dose of aspirin.
That was a good comment. So here we see the poll. You see it's changed. We saw before it was about half of you who would vote A. It's now 62%, and about 1/4 would reconsider here, and about 15% of you wants to see more data before considering closing these patients. So I think, at least as I interpret these data, it looks like these real-world data have impact on how people in the future will look at these patients older than 6 years of age. With this, I want to thank you, Ruby and Jeff, for excellent talks, discussion, and give your insight on this evolving field. I want to thank everyone who attended this webinar here, and of course to Abbott, who was organizing it. So have a nice rest of your day, and thanks a lot for joining.
Thank you,
everyone.